There are really two problems that we face. Just from a U.S. perspective, as an example, we're spending $2.7 trillion a year on healthcare. And over 70% of that is going to chronic disease management. So we've got this huge challenge of an increasing burden of illness on top of a system that's kind of needing to constrain its resources. In the US, it looks like this. Every 5 years, we've seen dramatic increases in the rates of obesity. And again, it's not just an American problem. If we look at, as an example, obesity growth in the world, it's dramatic. And if we look at the prevalence of diabetes in the world, it's dramatic. How do we, as leaders in healthcare, deal with this? How do we put that problem squarely on the same screen with the problem that says we need big changes in the healthcare system? So when you look at the causes of diabetes or the causes of obesity or the causes of cardiac disease, and you look at the causes of health, there's this big array of determinants of health. Can you find us healthcare? We're way down there in that little corner. That's the contribution that the healthcare system makes to health. So what this means to me is we need, as leaders, to open our eyes to think very differently about how we manage and what we're working in. Joanne Lynn, one of our faculty at IHI, says if we thought in segments that we'd be much better off in terms of designs. Because right now, we're trying to deal with each patient as they come in, and the clinical evidence and the processes of care don't match up with the needs of our segments. So at IHI, we've been thinking about this model of what are the leadership challenges of today. And I think what I'm seeing as I travel the world is that we're in a state of pretty rapid transformation. It's going to require the best of our leadership thinking. Because in the old days, we were in a system, it was much more segmented. And now we're moving to the second curve, which is really, if we're going to solve these big social problems, we need to start thinking about healthcare across the continuum. We need to move from segmentation and interaction to really understanding those needs and the social determinants and really thinking as healthcare leaders in a very different way. And as we move into the third curve, it's even more challenging yet. If you're on the first curve, if you're managing a hospital and you're thinking about quality, what are the leadership challenges on living, thriving on the first curve? Do we have widespread improvement capability? Do doctors and nurses and people on the front line across the organization know how to improve? Have you done the work you need on safety? Have you begun to engage with patients and families to understand where they're at? If you're thriving on the first curve, as an example, you might be like Henry Ford Health System in the United States that took a look at all of the safety problems in their system. They found about 20, and they built improvement capability and said, we're going to go to work at driving out these complications. This graph is from C. diff, the dramatic reductions in C. diff infections in the hospital. So they've got clinicians working hard across the hospital at improving safety. And then they've got the finance people tallying up the savings. And over $20 million in one hospital in 1 year through engaging clinicians in improving safety on behalf of their patients. I want to talk a little bit more about thriving on the second curve. And we really need to start moving outside the building. Here, we need totally different leadership skills. And here we need to understand not only improvement, but innovation. We need new partnerships. So I'll tell you a story from a patient I met in Sweden. I was actually walking through an academic medical center in Jönköping, Sweden, and I came across a building that I had never seen before. And I'm in hospitals every week. But I said to myself, what is this place? Where am I in this hospital? And they said, oh, you're in the patient self-hemodialysis building. I said, there's a whole building where the patients let themselves in and take care of themselves. And I met Christian. And Christian is the person who is a patient who I think is responsible for this. Christian is a mechanic at Saab Avionics in the aerospace industry who came down with glomerulonephritis in his 20s. and ended up on dialysis. And after a few weeks of being on dialysis, Christian, a mechanic, said to the nurse, I think I can do that. And so the nurse said, okay, and she taught Christian how to do his own dialysis. The next thing, Christian's teaching the 73-year-old lady in the next bed how to do her dialysis, and on it goes. So they set an aim that 75% of the patients on dialysis in this academic medical center would be doing it themselves. Now that's leadership at the front line. That nurse who said, I teach nurses, student nurses, every July how to do, they don't even know where your kidneys are. And I get this whole group of student nurses, and I teach them how to do dialysis. Surely this mechanic with his own kidneys at stake can learn how to do dialysis. When I asked Christian about this, I said to him and to the nurse, how did you find the courage to have this conversation? And Christian said he found it in understanding that when he did his own dialysis, and he did this through the research and through his own personal testing, he found that he actually could live his own life. He also said it was safer in his hands. That, of course, it was his bacteria, not someone else's. And he said, I always do it the same way. This is what Annette, the nurse leader, says. She says, I now manage this unit at half the cost. So it took a frontline leader to say, I will engage with the patient. It took a head nurse leader, to say, I can do this en masse. I can do this for 75% of the patients. And then it took the hospital CEO to say, well, if we could build on the efficiencies of this, let's put them in their own building. This is thriving on the second curve. And then I'll just wrap up with a word or two on the third curve. It's really thinking outside the box of the hospital entirely. It's going to look at entirely different leadership skills that many of us have not yet built, and really thinking outside with others in the community about how do we optimize health. So a quick example here in Memphis, Tennessee, we're working with the African American population, high rates of diabetes and heart disease. And in Memphis, what we were finding is that all the physicians and the hospital executives sitting around the table were not making any dent in diabetes. We worked with the community in Memphis, and we said, we can't solve this problem alone. So we brought in all of the church leaders, and we said to the church leaders, can you help us with diabetes? And the minister looked out at the doctors, and he said, you see these patients for 15 minutes twice a year, and you expect to put a dent in diabetes? He said, I see them twice a week for 2 hours. The minister said, I'll take diabetes, you guys work on something else. And what he started to do was on Wednesdays when people come into church for dinner, he shows them, this is the size of a plate that you're supposed to eat off of, not this. And so he's serving them on appropriate sized plates. And he's got them apportioned, like you're supposed to have this many vegetables, and it can't all be fried chicken. And so he's changing the way they eat by modeling. And then in all his sermons, he's saying, your health is sacred. And he's changing diabetes. We cannot. So I think we've got to, on the third curve, start thinking about engaging everybody in the community. It's going to take new definitions of an organization. It's going to take new ways to lead multi-generational organizations. Young people don't get managed the same way I did. It's going to take new ways of engaging patients like Christian, and new learning networks for all of us. So thank you so much for